Welcome to another podcast from AMCAIM, the American College of Artificial Intelligence and Medicine. I'm Dr. Mel Spiceman, President.
And I'm Dr. Ann Slesoritis, the Executive Vice President. Our mission is to explore the rapidly evolving intersection of AI and healthcare. Whether you're a physician, healthcare leader, researcher, student, or simply curious about the future of medicine, we're glad you're here. Thank you for joining us, and let's begin today's conversation.
Well, welcome to the podcast of the American College of Artificial Intelligence and Medicine. And today, it's our pleasure to interview a radiologist from the University of Miami, Fernando Collado-Mesa, who is a member of our organization. Fernando is a professor of clinical radiology at the University of Miami. He's also the associate vice chair of AI research and ethical use. And he's the assistant director of diagnostic radiology residency program, as well as being the medical director of Jackson Memorial Hospital Breast Health Center. He's done advanced certifications in artificial intelligence and imaging through RSNA, as well as AI in healthcare through MIT. And we're super excited to have Fernando on the podcast today.
All right. Well, welcome, Dr. Fernando. Can you tell us a little bit about your journey into artificial intelligence?
Thank you, Melon, and it is really a pleasure to be here. My journey, I think, is somewhat similar to so many of our colleagues in medicine. In my case, the journey started with headlines on the news. It was around 2015, 2016, when I saw news that Geoffrey Hinton, the godfather of artificial intelligence, predicted that in 5 years you would no longer need to train radiologists, that AI was going to replace all of them. And as you can imagine, that was a heck of a news to us.
Yes.
So it motivated me. I started reading about what AI was. I had barely heard about it, and even though I was using it a little bit, generative AI was not that common back then. It motivated me to look deeper into it. And I realized I need to educate myself into what this is, what it means for us as radiologists and for physicians and for medicine and healthcare in general. How is this going to affect us in any way? And what are the potential benefits and risks that this new technology will have? And that's how I became engaged with the certificates from RSNA, and then with MIT. This was all, on my free time, nights and weekends, motivated to learn about this. And it was a surprising journey because there were several things that I learned. First, that persons like Hinton were making assessment coming from a purely engineering point of view without any medical expertise. And that was obviously a flaw. It takes both fields working together to understand what both fields can bring to our patients, to healthcare, to improving care, and to assert the benefits and the risks. And a testament to that is I'm a radiologist, I'm still working, I'm still as busy, if not more, than usual. So I think my journey is somewhat similar to many of my colleagues, motivated by the need to learn and to know. I encourage all of us, all of our colleagues in medicine to do the same, get involved. I remember attending a meeting many years ago, and it was with a famous IT company developing some of these tools. And one of the colleagues at the table said, I'd rather be at the table, not on the menu.
I
That
love that.
really, that really conveyed my feeling. And I approached that colleague and said, you know what? I love what you said. We should all do the same. We should be part of this. We should take place in the development, the implementation, and the monitoring of these tools. And that's what I do nowadays.
Yes, that's incredible, and we share your enthusiasm and your mission for education. We have to. We have to. Thank you.
Can you explain the current role of AI in breast imaging today and where the biggest clinical impact has been?
Absolutely. Um, it's been a road for AI in breast imaging, and it started and is mainly driven by neural networks and machine learning algorithms. These are tools that look at images and can find features on those images and predict what those features mean. The first few studies comparing these tools to what radiologists were doing were reader studies. One of them famously comparing one specific AI tool to 100 radiologists reading screening mammograms. And those 100 radiologists span the experience length of those of us in practice, recently graduated, genital radiologists, fellowship trained breast imaging radiologists. And what the study found was that the AI helped all of them. It helped mostly the recently graduates. It also helped the general radiologists that don't read breast imaging as much, but it also did very well with the experienced breast imaging radiologists. And from there, more reader studies took place, and now we have a large quantity of them. But it wasn't until very recently that population large um, trials had taken place and the results have been published. And one example of them is the Masai trial, which is a trial that took place in Sweden. It was led by Kay Lan and the colleagues. And that trial in particular, the first results showed that AI supported screening mammography increased cancer detection by approximately 20%, meaning the radiologists that use AI to support their reading detected approximately 6.1 breast cancer per every 1,000 mammograms that they read. When they did the same without the assistance of AI, they detected 5.1, so about one breast cancer less when they were not assisted by AI. And the important thing is that it did this while reducing the radiologist's reading workload by approximately 44%. And that is also a major result. As we know, the demand for radiologists has been increasing. It's about 4% increase every year in the amount of imaging produced, while the number of new radiologists increased by about 0.4% per year in the last few years. So there is an increased demand for the radiologist workforce, more case volume, and to have a tool that reduces the workload while improving cancer detection um, was a fantastic finding and something that we will all looking forward and we're very gladly surprised.
Yes, thank you. So in the Masai trial, they used AI plus the human against two humans. So a human is always in the loop. So I was very impressed with what they found. So my understanding is AI read the report and then assigned it if it was low risk or anything higher than that. Low risk, then it only had the one radiologist reading. So interestingly, in Sweden, they have two radiologists that always read the double read. Do they do that in the U.S.? I don't think that's done routinely, but you can correct me on that.
That's an excellent point. And the newest and strongest evidence on AI role in a screening mammography has been coming from Europe. And like you said, it is important to understand the differences between the European mammography screening environment and the US system. For example, like you mentioned, in the Masai trial in Sweden, the comparison was between double reading by two radiologists and AI assisted triage of cases that would go to one radiologist, and the standard of care, which is reading screening mammography by two radiologists. Double reading is not routinely performed in the US. So this creates sort of a barrier to directly apply the
Yes.
result of the Masai and other Europe-based trials, like the AI trial from Spain, here in the US. Also, and very importantly, AI-only interpretation is not currently accepted practice in the US. So the Masai workflow cannot simply be adopted as is.
Yes,
There
that's
are practical issues, that you can think of when bringing those results into our environment. For example, reimbursement. AI, unfortunately, is generally not covered by insurance in the US, so facilities may charge patients an out-of-pocket fee when offering AI-assisted mammography. So, importantly, the Masai trials, the AI-TIC trials, and other, they provide results that show strong evidence that AI can improve screening performance and efficiency.
yes.
However, differences in US screening practices, regulatory acceptance, insurance coverage make that implementation more complicated than in Europe.
Yes. So I was impressed with the trial, but one thing specifically is the sensitivity was higher with AI and the radiologist versus the two radiologists, but the most impressive is that the specificity didn't change. So the false positive rate did not go up in comparison to the two groups. So
Absolutely.
I was particularly impressed with that. Okay, so my next question for you would be AI algorithms are often promoted as improving cancer detection on mammography. In your experience, where does AI truly outperform traditional workflows and where does it fall short?
So, in our experience, AI tends to outperform traditional workflow in detecting subtle findings. So, imagine you're looking at a mammogram, and if you are a trained radiologist, and even more so if you are a fellowship trained breast imaging radiologist, you have been trained to look for certain clues to indicate the presence of a finding that may represent cancer. Now, some of those findings can be very subtle and they can be very hard for the human eye to distinguish. AI really exceeds our finding those subtle findings. Um, for example, there is a study by McKinney and others that was published in Nature in 2020 where Google Health AI system demonstrated an absolute reduction in false negative of 9.4% in the data set from the US and 20.7% in a data set from the UK. This is very relevant. False negatives are a problem of a screening mammography. We know that approximately 10% of cancer may not be seen on a screening mammography by trained radiologists, and AI can help us with that. The AI TIC trial in Spain, led by Alvaro Rodriguez Ruiz and his colleague, further support that AI can safely identify examinations that are at a very low risk of cancer and then prioritize radiologists' attention toward high risk patients. The issue is that AI falls short is in context, and that's the value of the human in the loop. Uh, for example, history of prior surgery, where there's surgical changes, some benign findings that mimic malignancy, and the radiologist is aware of those because of the history. Uh, the presence of breast implants, which is relatively high in certain areas of our country and in the world, and rare presentations that are hard to come across to train the artificial intelligence. So deciding what is clinically meaningful and relevant versus merely suspicious, that's where the value of the human comes into place.
Yes.
We wanted to ask about the use of AI in detecting interval cancers. What are your thoughts on that?
So over the next 5-10 years, I expect that we will learn more about this. AI is really excelling in identifying women that are at higher risk for interval cancer. The most predictive imaging feature of those appear to include subtle developing asymmetry, architectural distortion, density-related masking, parenchymal complexity, etc. The KARMA cohort, led by Michael Erickson and Per Hall, showed that AI-derived mammographic features predicted interval cancers more accurate than breast density alone. The key, I think, is not just detecting today's cancer, the one that is there in front of us, but recognizing features that looks biologically to be high risk. And for example, the Swedish Messiah trial showed that AI-supported workflow reduced interval cancer, and particularly invasive aggressive cancers, which are the really relevant when you want to have a screening that reduce mortality and do it in an early detection fashion.
Great.
Yes.
Now, regarding personalized cancer risk, there's this movement beyond just breast density to an AI-derived risk model. How do you see AI changing personalized breast cancer risk prediction moving forward?
This is also a great area where AI has shown relevant. As a matter of fact, there is an FDA approved tool that is commercially available that the NCCN has included into recommendation for breast cancer screening. And what it takes into consideration is elements in the image, the mammogram image, that the radiologist is unaware of. These are pixel-based elements, feature, texture elements that the human eye is not able to take into consideration, and the AI does. And these tools and the research on them has shown that looking at the image characteristics, AI can predict which women will have a higher risk of developing breast cancer in the next year, the next 5 years, and the next 10 years. As a matter of fact, a side-by-side comparison of one of these tools with the gold standard used today in clinical practice, which is the Tyrer-Cuzick model, showed that the AI was more accurate, significantly more accurate than the current gold standard. I expect that this will get even better because the AI tool was looking only at the image. And I expect that using multi-model AI, where the eye can use clinical data available in the electronic medical record, patients' other risk factors like age, menarche, reproductive history, family history, and even genetic information when available, will only improve the performance of the AI. So I foresee that this will bring about a major change of a screening with a model that uses a one size that fits all mammogram every year for everybody versus who will need adjunct screening with breast MRI, with contrast enhanced mammography, or even with ultrasound, and who may need less screening. So I think that's where we're going, where we're going to be more personalized from a medical point of view about what screening for breast cancer women need, and a step beyond that, even preventive measurements, such as hormone treatment
Yeah.
to reduce the risk of future breast cancer.
Right. Great. Now, shifting gears a little bit, Anne and I are really interested in this notion of opportunistic screening using imaging that's already been done and going back into it to predict things. Now, specifically, we want to ask you about this breast arterial calcification concept. And you did several papers around this, but specifically, there was one in which you partnered with the computer engineering department at the University of Miami to develop a tool that could identify calcifications. As you know, our organization is this collaborative group where we're trying to bring together physicians like yourself with computer scientists, biomedical engineers. Can you kind of give us some backstory about how you were able to do that at the University of Miami?
Of course, thank you. It's a very relevant question and very important topic. It was the same. It was personal and group motivation. There were a group of us in our department that were initially interested in AI. We reached out to the Department of Computer and Electrical Engineering, and we expressed our interest in collaborating. So what they did is, please put together a list of things you would like to collaborate with us. And we did that. And I was the one that submitted the breast arterial calcification. So AI to find and measure how much breast arterial calcifications is present. And that one was one of the lines of work that was agreed upon. So it's very important that you and your colleagues have that initiative, that you reach out to your engineering colleagues, even if they are in other campuses, and bring about collaboration. It would only improve the work that we both do separate. We need each other for this to really work properly. So, regarding breast arterial calcification, actually, in our group, we don't call it opportunistic screening as a matter of semantics. We call it preventative radiology. And I think behind that is, if we do this, I think we can use data that is mostly already available on imaging and that has been underutilized or not utilized at all to prevent something, a healthcare event, from happening in the future. And in the case of breast arterial calcification, there is now ample data available of the association that it has with cardiovascular disease, atherosclerotic cardiovascular disease, and major adverse cardiovascular events. And in that sense, why use AI? Well, breast arterial calcification have been recognized by us as not malignant, not suspicious, what we call a group of benign calcification. There is no standardized reporting. As a matter of fact, you don't have to report it, except for one state, and we can talk about that. It's a major change that is coming down. But there is some valuable information there. So women that have breast arterial calcifications on their mammogram have been shown to be at an increased risk of women that do not show this type of calcification to have a future adverse cardiovascular event. Furthermore, there is a recent study from Emory where they developed one of these AI tools, somewhat similar to ours, where they look retrospectively at women as they had, and they as they had breast arterial calcifications on their mammogram. And this was a large group of women, over 123,000 that they looked at. And they found that when they classify them as not having any breast arterial calcifications versus mild, moderate to severe, there was a dose response to the risk of having a major adverse cardiovascular event in the future. Even the ones with mild calcification had a relevant increased risk. And I think what is mostly important to our cardiology and healthcare, primary healthcare, family medicine colleagues, like have patients and they want to look at their risk for future event, for treatment, meaning lifestyle modification, etc., and medication treatment, is that they compare the results of their AI model risk to the prevent risk, which is the currently used risk assessment by the American Heart Association. And even when taking into account the prevent risk, the AI show an additional relevant element that indicated a higher risk. So it's something that is fascinating. It's a piece of information that has been sitting there. We know that we have a vast amount of digital data, whether it is in the form of text, laboratory results, genetic testing, imaging, that we are barely scratching the surface of utilizing it properly. And AI can help us do that.
So in your paper in the Journal of Breast Imaging, this is where you were discussing the observational data that AI can identify the breast arterial calcification. We tend to call it opportunistic. We're really excited about opportunistic because it's so exciting, this data that's there for other reasons. And it's always been there, and we can go back and find so many things what AI can see that we can't see. It's kind of fascinating. But obviously we're going to need some randomized controlled trials. And you mentioned the European the study from the Emory group. It's a retrospective cohort study. Those can carry a lot of weight as well, but I don't think we have any retrospective, randomized controlled trials
No, we
yet.
don't. You are absolutely right. On this topic, we have to be cautious and move ahead cautiously. You know, we still need a standardized reporting from radiologists who read mammograms. We need outcome-based thresholds. If I report this amount, will that reduce the occurrence of that outcome? In this case, myocardial infarction or stroke. Where is that threshold that we need to use? We need to learn about that. And also, very important, we need to establish referral pathways. It's not enough that a radiologist mentions something in a report if no action is going to be taken about that by the patient and those who take care of the patient. So, we need still proof that acting on breast arterial calcifications on mammogram really improves patient outcomes. I absolutely agree with you.
So to get that consistently in a radiology report, a report about breast arterial calcification, and make it part of routine clinical practice, what do we as physicians need to do to make that the new standard? What has to happen?
I think we need to have this discussion in our open forums, such as this one. The meeting that we will be having in October is a great place. There are societies that are dedicated to breast imaging radiology, like the Society of Breast Imaging, and I am a proud member and fellow there. We're talking about this, we're discussing this topic. There are others, for example, in Canada, the Canadian Society of Breast Imaging, who have issued a statement and recommendations about what radiologists reading mammography should do. But I think that more exchange of information, more advocacy, and truly doing a forensic analysis of what the available evidence is can help us move forward.
Okay, great. Thank you. In the Journal of Breast Imaging 2025, you published an article on bias in breast imaging. So, what takeaways can you share with our listeners regarding bias?
Yes, bias in AI is actually a major concern. Um, we have learned that AI performance can vary by race, by ethnicity, in breast imaging, for example, by breast density, by age, even by cancer subtype. It can vary by imaging vendor, the acquisition protocol that we follow in radiology, and even the site workflow. There is an element that has been not very well explored, which is the interaction between the human and the AI. And I'm happy to say that there is currently a trial in the US, and the University of Miami is part of one. That trial is one of the sites, is the PRSIM trial, looking at that interaction. The trial just started. It's going to take about 5 years to see results. But one of the elements that the trial is looking at is what is called automation bias. As humans, we tend to trust an outside automatic source. If the AI is telling us there is something there and that something is bad, as humans, over time, we tend to trust that. And if we are in the middle of a busy day and we need to get through all the cases, then we're going to pull back and rely on it. And that is a major topic of concern for us. Uh, there is undergoing research. The PRISM trial is one of them. Uh, and I think it's important for all of us to be aware, to talk about this. It's important for all of us to learn. If I'm going to be using an AI tool, how was that tool developed? What data was used from which population? What were the results? Can I assume that those results are going to be the same in my site, in my population? You cannot. Uh, the FDA way of looking at AI has been somewhat limited, where developers bring in some data that show that it performs as well as the previous available tool. Uh, you don't have to have a large amount of patients in when you test it. You don't have to have a, uh diverse population in which it was tested. You just show, look, I tested it and it did as well as this one that was available, or maybe a little bit better. Well, if you look into it, for example, in Miami, where we're based at, there is a large Hispanic population. So I need to know, with this AI developed in, let's say, a Swedish population? If it was, I better locally test that AI before I go ahead and implement it and see how it performs. But furthermore, bias can occur over time. You may say, it performs really well. Let's go ahead and implement it and use it as part of our workflow. Well, over time, your data may drift, your population may change, the equipment that you're using may change, the protocol that you're using may be modified, and all those variables affect the performance of the AI. So it is also very important to have a systematic monitoring of your AI performance. Never take your eyes off of it.
Yes, that's a that's an excellent response. And how do we get physicians more involved with looking at the transparency of it? Because sometimes I'm guessing a lot of people just take it blind faith. They're at a hospital system and they're just using what's available. How do we get people to question that?
I think there are two elements. One of them is the education element, and I think the college is doing a great job about that, and we should continue to work in that as well as others. And there is the regulatory element that can be national, state, or even health system based. So we need to educate ourselves. We need education on the risk of bias, understanding what is bias in AI, and learning about AI, its potential flaws, as well as its benefits. So, awareness, education, and regulation. Those are, I would say, the three pillars in which we will succeed.
Well said. Thank you.
Regarding the future of breast imaging, how do you envision the relationship between the radiologist and AI evolving? And will it be a second reader, a triage system, or do you envision something completely different?
So this is a perfect circle. We came back to my history. What motivated me? It was actually being afraid of being replaced by AI and not having a job that I love, that I have worked so hard to educate myself as a breast imager. So I, pay attention to the experts in our field in medicine, and the expert on the engineering side that have true experience, knowledge, and that have worked with experts in medicine on this topic. And I honestly don't see AI replacing the radiologists. I see in the future a both of us working together. AI is very good at certain things, and I was talking about recognizing sector textures and pixel level data that humans are not. But humans are very good at the context and the human element and additional information that AI doesn't have access to. Uh, it may get to the point where some expert had predicted that radiologists would be more like information managers. We will have information from the images, information from the AI system, and it will be up to us to curate that information, decide on which one to act and which one not to act. And that probably would give us the opportunity to have more time to interact with our colleagues, the referring physicians, and work more closely with them rather than just spend hours and hours looking at images. And it will also possibly give us more time to interact more closely with our patients. It's something that in breast imaging we do on a daily basis, but other areas of radiology don't. So I think the value of our work will increase because it will be further advanced by the presence of AI.
Yes, very well stated. I think for the remainder of our time, we'd like to do a few rapid fire questions with you, if that's okay. The first one is, what's the most overhyped claim about AI in radiology?
That AI will replace radiologists. Don't see it. And it's not me, it's not a personal opinion. I
Yes.
want members and those who have access to our podcast to understand this. It's the opinion of many well-renowned, recognized experts.
We agree.
What AI application in breast imaging will become a new standard of care?
I think it will. Um, we have to still understand the differences when it gets developed and tested and used in other environments. As I mentioned, each country and healthcare system is different. There is a regulatory element, there is an element of getting more data, more evidence base to make the right decisions. But I think we will get there at some point in time.
Okay, something we're really interested in is how do we prepare the trainees on AI-enabled radiology?
What an excellent question. Thank you. We actually have been looking at it at our residency program. And we had many questions. Do you want a radiology trainee to start using an AI tool that is going to help her or him find something on an image from day one? Or do you want to delay when they have access to that? So those are questions. If you don't, are you preventing them from learning to work together with AI and, reap the benefits of having an AI? Or are you de-skilling them or on-skilling it? Never develop a skill that is needed traditionally, historically, to be a good radiologist, to be able to look at an image and make that subtle finding that sets you apart and then help your referring provider and your patients. So I think we're early on this. I think many societies and educational boards are looking at this topic. For now, I would go back to awareness and education and when to introduce the use, how to do it, and how to monitor how our trainees are using it and whether it's really helping them or not is something that is coming down the pipe and that is very much needed at this point in time.
Yes, it's a challenging situation.
All right, our last question is around some fun facts about you. Nothing medical, but what would you like our listeners to know about the human side or the fun side of you? What are some of your interests?
Well, I come home to a karaoke machine
We love karaoke.
and sing in English and Spanish.
Oh, wow.
And so, and it makes me happy. I'm sort of not good at singing in front of big crowds, but I do it here in my house, and it helps me with reduce the stress level coming from work, a tense day, and doing
Yes.
karaoke for me is fantastic. It makes me happy. It helps me. So what I would say is find what makes you happy. Uh, we all have that little thing that tickles us. We all need that. Our work is very intense, and we need that reset to go back the next day to be the best we can.
Yeah, karaoke has been something we've incorporated for our joy as well. And we were known for having an annual after New Year's party at our home for our residents. So hundreds of residents have come to this after New Year's party over the years. And the main
To our house, yeah.
at our home, the main activity after the meal is karaoke. And we both surprise them with our ability to sing rap songs.
Not me, that's Mel.
We do enjoy all the new music, and we're really up to date on all the current artists.
But karaoke is so much fun. So
now,
much fun.
now you're in Miami, and the last time we were out in Miami, we did just as tourists for fun visit a street or a block in which the lineup of people living on this block was Shakira, Calvin Klein, and the Bee Gees. So
Was
they're
Paul McCartney there too?
no, no,
Okay.
they were all next door neighbors. So that was a cool thing for us to see that.
Oh, we
So
love Miami.
well, I have to say, Fernando,
Fernando.
it was such a pleasure having you on the podcast. This was amazing. Um, for our listeners, if you were enjoyed what you heard today and you want to take it to the next level, come live to our scientific session. It'll be held here in Chicago, October 9th and 10th. You can hear Fernando give the latest update on the 2026 most important papers around AI and breast imaging. And we look forward to seeing you there.
We're very excited, and thank you so much for being here with us today.
Thank you. Thank you. It's been a pleasure.
We hope you enjoyed this episode of the AmCAIM podcast. To learn more about the college, visit our website at www.americancollegeaim.org. Also consider attending our annual scientific session this fall in Chicago at McCormick Place. Thanks for listening.